to speak, what will we do here? Yes. So the rehabilitation of speech following laryngectomy is a very important topic, repeatedly asked. Yes. So what were the modes of rehabilitation of speech following laryngectomy? Yes, the earliest was the esophageal speech. The esophageal speech was that the patient was made to learn to swallow air before he spoke. So not only that much, he will swallow the air, and now he will regurgitate the air. He will regurgitate the air to vibrate the hypopharyngeal segment that was behind the larynx. Behind the larynx, we have the hypopharynx. We have removed the larynx. What is left is the pharynx, the hypopharynx. So he will use that regurgitated air to vibrate the hypopharyngeal segment, and that vibrations that are produced, now he uses that to produce speech. That is what is known as esophageal speech. That was a very, very difficult form of speech to develop, and patient could just swallow air, speak 2-3 words, and then again swallow air, again speaks 2-3 words. And not only that, it used to take months to learn. Maybe most of the patients never were able to learn it. So that was what is known as esophageal speech. Now, nowadays, what we have developed is the best form of speech following laryngectomy. That is what is known as the tracheoesophageal speech. This is the second form of speech, tracheoesophageal speech. This is the best. This is the best form of speech following laryngectomy. Here what is done is, just see here, a valve is attached. This is a valve, okay? A valve is attached in between. This is the trachea. This is the trachea that you have pulled out and sutured to the skin outside. Now behind this we have the pharynx. The food is going here. It used to come to the larynx. The air used to come to the larynx, and the food goes from the oral cavity to the hypopharynx, right? The larynx we have removed. So now the trachea, in between the trachea and the pharynx behind, right? So in between the trachea and the pharynx behind, what we do is we put a valve there. This is a one-way valve through which air can go into the pharynx, but the food from the pharynx cannot come into the trachea. This is a one-way valve. Now what will happen here is, what we need actually is we need air to vibrate the pharyngeal segment so that some voice can be produced because of vibration of the pharyngeal segment. So from where do we get the air? Here what we do is we have connected a valve in between the trachea and the pharynx. During expiration, whenever a patient wants to speak, during expiration, he will close this opening of the tracheostome. Now, all the air during expiration will get diverted through the valve to the pharynx. That air will vibrate the pharynx, and that will be used by the patient, those vibrations will be used by the patient to produce a speech. This is what is tracheoesophageal speech, and this is considered as the best form of speech. Why? Because the air that is coming is a lung powered air. So a lot of power of the air, a lot of vibration can be produced of the pharynx to produce a good voice. This is what is known as tracheoesophageal speech. And the valve that we put here appears something like this. So this one part is in the trachea, the other is inside, the one is outside in the trachea and the other is inside, that is in the pharynx, toward the pharynx part. And when it is put, this is how it appears. This picture was given to you in your exam and asked that what is this mode of rehabilitation for speech, or what is this type of speech? Yes, what is this surgery? So this is the tracheoesophageal speech, and this prosthesis comes in the name of many names. The famous ones are the Blumsinger and the Pange valve prosthesis. And again, this picture has been given to you in your exam and has been asked that what is the mode of speech that this patient is using. So yes, you have to notice whenever this is given to you, just try to see whether you are able to see some small valve or not. Don't write this as esophageal speech. Yes, this is a tracheoesophageal. The valve has been put there. See that properly. That is the only thing that you need to see if a picture like this is given to you. Now, whenever this patient wants to speak, what he will do is, during expiration, he will put a finger here and he will speak. He will use this air to be diverted, the expired air not to come out but to get diverted to the pharynx, and he will use this air to speak. Now, this was a problem because if he is doing something, some work, both his hands are involved. So then if he wants to speak, he will have to close the tracheostome opening with one finger. So nowadays there is a button which can be used, a button which can be closed here, and that automatically does the function of the finger, and that is what is known as a hands-free tracheoesophageal speech. So the valve that is put inside is the same that we put inside. The only difference in hands-free is that the function of your finger is being done with a button there. Now let us quickly see a hands-free tracheoesophageal speech. In this patient, post-laryngectomy, the tracheoesophageal puncture was done and the tracheoesophageal valve was placed. But yes, he was disturbed because of the hand being used every time he had to speak. So the hands-free was put, and just see how his voice is.
It was the most important moment that Dr. Selby treated hands-free, and I am able to speak without putting my finger over my stomach.
Now sometimes granulations form at this valve area and this valve closes, or it repeatedly gets infected and it needs to be removed. Then in that case, what option can be given for speech to the patient is something which is known as electrolarynx. Yes, so that is what is known as electrolarynx. This is the third form of speech following rehabilitation of speech that we can give for post-laryngectomy patients. Electrolarynx. Electrolarynx. Now what is this? This is a device where he places this electronic device which just produces vibrations. So it is placed against the neck and it produces vibrations, and those vibrations are used to produce speech by the patient. This produces a very monotonous robotic voice. How the robots speak, that is the type of voice these patients have, robotic voice. So this is how he will place it, and he will speak whenever he has to speak. And now let us quickly see how the voice is when the patient uses an electrolarynx. Now in this patient, the patient had a TEP, a tracheoesophageal prosthesis earlier, and which failed, and because of which he is now using a electrolarynx.
पहले मेरे टीवी लगी हुई थी, 2-3 साल तक लगी रही मेरे, उसमें प्रॉब्लम होने की वजह से मैं अब ये मशीन यूज़ कर रहा हूँ. अब इस मशीन से मुझे कोई भी प्रॉब्लम नहीं है, मैं अपना बिजनेस कर रहा हूँ.
So what we saw is that post-laryngectomy, when we have removed the larynx, we have taken care of the speech quite in a good manner. Patient is at least able to speak and communicate, right? Now what can be the other problems that can occur following laryngectomy? Now when we are breathing through the nose or when we are breathing through this tracheostome, will it make a difference? Yes, we know that nose has a very important function of temperature regulation, of humidification, which means that if the patient is breathing through here, this function of the temperature regulation and humidification of air is not being taken care of. So the patient has repeated, he has dry air which is going inside, he has repeated crusting of the airway, he has repeated cough, repeated infections. So for that, can something be done? Yes. So to filter the air and to humidify the air, we can use a prosthesis which appears like this. This is what is known as a heat and moisture exchanger. So this takes care of humidification and filtering of air. Humidification plus filtering. Now also, if the patient is not breathing through the nose, does the nose have another very important function of smell, of olfaction? Yes, so if the patient is not breathing through the nose, patient is breathing through here, will this patient be able to smell? Will there be loss of taste and loss of smell in this patient? Yes or no? Yes, we know that the taste, the flavor of the food also comes from the smell. So yes, that is also a problem following laryngectomy. So can that be taken care of? Yes, that can also be taken care of. So when we want to give olfactory rehabilitation, this can be done by a procedure which is known as polite yawning, and this was a question last year in exam. Olfactory rehabilitation is by polite yawning. Polite yawning. What is polite yawning? Polite yawning is, how do you yawn? You can yawn with your mouth open, or yes, you can yawn with your mouth closed. So what is polite? Yes, when you're yawning with your mouth closed. So what happens? Just try to do that and see. When you're yawning with your mouth closed, what happens is like that. Yes, so you create a negative pressure in your mouth. Do that and see. Yes, so when you create a negative pressure in your mouth, that induces air from the lungs to come out. Just do that and see. You will see that when you do this, you ultimately what you do is you do expiration, and that air goes through your nose out. So whenever you are doing polite yawning, that creates a negative pressure in the oral cavity that induces expiration, airflow through the nose. So when the air now goes through the nose, it reaches the olfactory mucosa and the patient can get some sense of smell. So that is what is known as polite yawning. Yes, you just need to know this word, and you can just try this and you can see how it is inducing nasal airflow. So this is induces nasal airflow. Nasal airflow, and the patient can smell. So yes, we can take care of the speech. Following laryngectomy, we can take care of the breathing. We have made a permanent tracheostome. So the patient is breathing through here. We can also take care of the drying and the filtering of the air, the humidification of the air, that is by a HME humidifier, a moisture and a humidity exchanger. We can also take care of the olfaction part. But what we cannot take care is of the chest fixation. We know that larynx has important function of when the vocal cords adduct in midline, the subglottic air pressure, the intrathoracic pressure builds up, and that stabilizes the chest, and that helps you to lift heavy weights, and that also increasing the intrathoracic pressure helps in coughing. So the cough part and the lifting heavy weights, that still cannot be taken care of. So there is still inability to lift heavy weights and inability to cough.